Thank you, dear all, for attending this online Zoom webinar. I will start a series of webinars called the Nephrotube Teaching Case of the Month. I will try to present every month a real case from my clinic to demonstrate or discuss some of the clinical approaches for common cases that we are facing in our clinics. This month we have a case which is a young female patient that was presented to my clinic with non-nephrotic range proteinuria. The recording of this lecture and all lectures of Nephrotube will be available on Nephrotube YouTube channel. And for sure, please join our Facebook group, follow our Facebook page for further announcements of the coming webinars. Let's start by the case history. The case was 35 years old, non-married female who is working as a nurse in a hospital. Her presenting complaint was frothy urine and mild lower limb edema. There was no history of hypertension or diabetes mellitus or any other medical condition. There was no relevant surgical history, no family history of any kidney diseases. Clinical examination of the patient showed normal findings except for mild lower limb edema. So this is a 35 years old female. The only positive data in her clinical presentation, history and examination is only mild lower limb edema, and from history there is frothy urine. All other data in the history were negative. All other data in the examination were normal. Her serum creatinine was normal, 0.52 milligram per deciliter. Serum urea was normal also. Hemoglobin 13.1. White count was normal. Platelets were normal. Urine analysis showed protein 2 plus at 25 RBCs per high power field. Serum albumin was 3.7, considered normal. And here ultrasound abdomen and pelvis showed no positive data except for colonic gaseous distension, bilateral renal gravels, some colitis, and left ovarian cyst. Her kidneys were average in size, normal parenchymal thickness, and normal echogenicity. No back pressure changes are seen. So from the investigations that were done at her presentation, the only positive sign or investigation was the protein 2 plus and the 25 RBCs per high power field. Now going to question 1. I will show the question for you and you have to interact. Select the correct answer. Now, select what is your next step in this patient. Would you do kidney biopsy, urinary protein quantification? Will prescribe for her ACE inhibitor or ARB? Just assurance and follow-up. Please choose your answer and click submit. So now we have one who selected 5% selected kidney biopsy, 89% selected urinary protein quantification, and 5% just assurance and follow-up. The correct answer is, this is the results. These are the results of the survey. For sure, the correct answer is urinary protein quantification. Why urinary protein quantification are the correct answer? Before showing you why urinary protein quantification is the correct answer, I will launch question 2 at first. So please answer it, and then I will show you an important approach for this case. So this is question 2. I told you that the correct answer in the past question was urinary protein quantification. The question now is, how would you quantify proteinuria in this patient? Please select one answer. Urinary albumin creatine ratio, urinary protein creatine ratio, or 24-hour urinary protein. Okay, please, all of you, try to join us in this pool. Okay, I will end now the question and show you the results. Most of you selected 24-hour urinary protein. The second answer that you selected was urinary albumin creatine ratio, and the final urinary protein creatine ratio. Okay. We have to put in mind that this case is not diabetic, not hypertensive, no history of chronic kidney disease, and she has proteinuria. Assessment of albumin in urine, for example, albumin creatine ratio, is not widely used for non-diabetic forms of glomerular disease and out of chronic kidney disease. If you have patient with suspicion of proteinuria, but the patient is not chronic kidney disease, not diabetic, it's better to assess all the protein in urine, not only albumin. So the answer that was urinary albumin creatine ratio is incorrect answer. So we have to choose now between protein creatine ratio in urine or 24-hour urinary protein. For sure, you have to finalize your assessment of the patient with 24-hour urinary protein. As I said here, it is widely used albumin in diabetic kidney disease and CKD. For sure, two, this is a patient, young age patient with no chronic history of any disease. There is a suspicion of glomerulonephritis, for example, or even tubular disease. We don't know the amount of protein in urine yet. So we have to quantify the total protein in urine. You have to quantify it with 24-hour urinary protein or urinary protein creatine ratio. It's okay to start by urinary protein creatine ratio to be sure that there is proteinuria, but you have to finalize your assessment with 24-hour urinary protein. So the most accurate and correct answer is 24-hour urinary protein. And I'll show you now the difference between different tools to assess total protein in urine. The first, assess total protein in 24-hour urinary collection using the 24-hour urinary protein. When to use this test? We have to use this test to confirm the diagnosis of glomerular disease, and this is an option in our case. Second, when initiation or intensification of immunosuppression is necessary in our patient, if you have a patient which is diagnosed as a glomerulonephritis, and you want to change or intensify your immunosuppression for this patient, you have to reassess by this test, not by protein creatine ratio and not by albumin creatine ratio. The normal 24-hour urinary protein is less than 150 milligram per day. Non-nephrotic range proteinuria between 150 milligram and 3.5 gram per day, and nephrotic range proteinuria more than 3.5 gram per day. So if you are assessing a patient who is suspicious to have glomerulonephritis, you have to do this test. The second is spot urine protein creatine ratio. It should be a spot first morning urine sample. You have to use it only for follow-up, not for diagnosis, and not to be used when initiation or intensification of immunosuppression is required. So it is not recommended in our case, because in our case, we are searching for diagnosis, not for follow-up. So if you started in our case by urinary protein creatine ratio, you have to confirm your diagnosis by 24-hour urinary protein. These are the normal values. I will not go through them. And finally, what is called estimated total protein excretion rate, but this option is not familiar. We are using between these 2 points. So the correct answer, the most accurate correct answer in the past question is 24-hour urinary collection. For sure, we have to quantify protein in this case before going through biopsy, because in the first question, some of you selected kidney biopsy. We cannot do kidney biopsy just on urine analysis, non-quantitative estimation of protein with 1 plus, 2 plus, or 3 plus. We have to quantify protein first before we go through the biopsy. So again, here, How would you quantify proteinuria in this patient? The most correct answer is 24-hour urinary protein. Back to our case, we collected the 24-hour urinary protein and it showed 2.3 gram per day. It is abnormal protein excretion rate, but it is non-nephrotic range proteinuria. So now, question 3, you know that this case is totally free regarding her history and the clinical examination. She has no past history of any chronic medical condition. She has no any familiar history, and she has only proteinuria 2.3 gram per day. So the next question is, uh, 1 minute. The next question is, order more investigation for evaluation of glomerular disease. I mean, what is your next step? Sorry, the question is incorrect. The question is incorrect. The question, I will end it and I will go through the answer directly. In this case, I will ask the question and you answer in the chat. In this case, would you order more investigations to identify the cause of glomerular disease? For example, you order ANA, anti-double strand DNA, C ANCA, P ANCA, or you will go to biopsy directly, or you will try to know the type of protein in urine. Please answer in the chat box because the question was incorrect. Okay, we have more investigations. We have serology, order more investigations, one biopsy. Okay. Okay, most of the answers with order more investigations. The list is for knowing the type of protein in urine. Okay, thank you for your participation. I will show you now a clinical approach for non-nephrotic range proteinuria. If you have a patient with non-nephrotic range proteinuria, you have to see if there is active urinary sediment in the urine analysis, for example, glomerular hematuria or white blood cells, white blood cell casts or white blood cells in absence of infection. Because the presence of white blood cell casts or white blood cells in absence of infection in a patient who is at suspicion of glomerulonephritis, this is a suspicion of glomerulonephritis. White blood cells can be seen as a marker of activity in our patients. So in patients with non-nephrotic range proteinuria with active urinary sediment in this form, for sure, this is non-nephrotic range proteinuria with glomerular hematuria, and you have to evaluate for cause of glomerular disease. If the patient has no active urinary sediment, no glomerular hematuria, and no white blood cell casts or white blood cells in absence of infection, check the kidney function, if it is abnormal or normal. If abnormal kidney function, so you have to do urine protein electrophoresis to know the type of protein in urine. If proteinuria is mostly albumin, so you have to evaluate this patient for glomerular disease. If the proteinuria is not mostly albumin and the electrophoresis showing monoclonal light chains, so evaluate for multiple myeloma and other monoclonal gammopathies. And if not showing monoclonal light chain, you are facing a tubular proteinuria, especially if it is less than 2 grams per day. And you have to evaluate for tubulointerstitial disease. Regarding urine protein electrophoresis, I want to mention another option, alternative for urine protein electrophoresis. To know the type of protein in urine, the most accurate is to do urine protein electrophoresis. But if it is not available, the alternative option is to do what is called urinary albumin, sorry, okay, urinary albumin protein ratio, albumin over protein from a sample one spot urine analysis. If the ratio between albumin and the protein is more than 0.4, so it is mostly glomerular proteinuria. If it is less than 0.4, so it is most probably multiple myeloma or tubular proteinuria. this ratio will not be able to differentiate between myeloma and the tubular proteinuria. If the patient has normal kidney function and no active sediment, and normal kidney function, you have to repeat urinary protein assessment. If normal, the repetition of protein assessment, how to calculate, we will leave the question at the end of the case, okay? Repeat urinary protein assessment. If it is normal, so it was transient proteinuria, especially if the proteinuria was less than 1 gram per day. Transient cause of proteinuria as fever and exercise. If it is abnormal after repetition, and the patient age is less than 30 years or no, if it is not less than 30 years, so it is isolated non-nephrotic range proteinuria, and you have to do urine protein electrophoresis for assessment of the type of protein in urine. If the patient is less than 30 years, you have to exclude orthostatic proteinuria. I will not go in depth now for how to exclude orthostatic proteinuria. And if orthostatic proteinuria was excluded, so again, it is isolated non-nephrotic range proteinuria. So this is a practical guide for diagnosis of the cause of non-nephrotic range proteinuria. So where do you think our patient is in this approach? Where do you think our patient is in this approach? Our patient, these are the investigations of the patient. Our patient is here. Our patient has non-nephrotic range proteinuria with hematuria. So we have non-nephrotic range proteinuria. For sure, we didn't mention in the case that we examined for dysmorphic RBCs to say that it is glomerular hematuria, but it is not mandatory to do in all cases or search for all cases for dysmorphic RBCs. If there is a high suspicion of glomerular disease, for example, we have non-nephrotic range proteinuria and hematuria in a patient with no any other signs or symptom of urological disease or urinary tract infection or stone, so it is most probably that this hematuria is due to glomerular disease. So now, as you all said, that we have to evaluate for other causes of glomerular disease. So to evaluate for glomerular disease, you have to take drug history. We took drug history from the patient and she didn't take any drugs. She has no any constitutional symptoms. There is no purpura or rash or photosensitivity, arthritis, arthralgia, myalgia in our patients, and there is no any sign or symptom suggesting malignancy. In general, in any patient where you are evaluating for glomerular cause of disease, initial testing should be based upon clinical presentation. But the clinical presentation of the case were not pointing for a specific disease to investigate for this disease. For example, she has no lupus symptoms, for example, to search for lupus. So in absence of a specific clinical presentation, you have to do these investigations for all cases which are in suspicion of glomerular disease. You have to do C3, C4, ANA anti-double strand DA, ANCA ELISA for proteinase 3 and myeloperoxidase, and virology test. We did these investigations for our patients. All these investigations were normal and negative in the patient. Complement were normal, C3 and 4. ANA was negative, and double strand was negative. C ANCA, P ANCA were negative. Her virology statements were normal and negative. So the next question is, would you biopsy this case? The answer is yes or no. Okay, most of you went to biopsy of the case. Okay. I will show you an approach for the consideration of renal biopsy or kidney biopsy in patients with non-nephrotic range proteinuria. And then I will ask you again if you changed your mind regarding to biopsy or not, okay? In patients with non-nephrotic range proteinuria, with urine sediments, as here, non-nephrotic range proteinuria with active urinary sediments, The gold standard is biopsy, as in our case, okay? But I have to continue. Because again, after getting the kidney biopsy, you have to re-evaluate your patient with more investigations according to the reported pathology findings. You have to search for the secondary causes of the reported pathology findings. But under some circumstances, some experts treat glomerular disease in this patient without kidney biopsy for confirmation and diagnosis, and may consider kidney biopsy later on according to the response of the patient. So the gold standard for sure here for diagnosis is kidney biopsy, but some may wait. The second situation is isolated non-nephrotic range proteinuria without hematuria, like here. So the first option, we have proteinuria with active sediment. The second option, we have isolated non-nephrotic range proteinuria without urinary sediment. In this situation, most experts, if proteinuria is more than or equal to 2 grams per day, perform kidney biopsy. If proteinuria is between 1 and 2 grams per day, they perform a kidney biopsy if there is evidence of clinical or serological clues suggesting a systemic disease, or if there is a possibility of hereditary disease. And finally, if proteinuria is less than 1 gram per day, they follow up the patient, and kidney biopsy is usually performed if the degree of proteinuria increases and persists above 1 gram per day, or if the patient develops new glomerular hematuria, hypertension, or a reduction in GFR. So after you watched the two approaches that I showed to you, I will ask you now a question. Please select. You said before yes for biopsy, and you still insisting on biopsy. You said before no for biopsy, and you still insisting not to biopsy. You said yes before for biopsy, but you changed your mind and you will not biopsy. You said no before, but you changed your mind and you will biopsy. Okay. Please, all of the attendees, please engage in our activity. Please select the most suitable answer for you. I am waiting for more answers. Okay, let's show the results. 78% of the attendees said yes before, and they still insisting on biopsy. 7% said no, and they still insisting not to biopsy. 2% said yes, and they changed their mind and they will not biopsy. And finally, 13% said no and changed their mind and they will biopsy. So the majority will biopsy. The majority will biopsy. Okay, let's say an important point in this case. I will ask a question. Would you suspect? I will hide the biopsy. I will ask the question and please answer in the chat. Would the biopsy change if there is a possibility that the biopsy results will change, or the way of the management of this patient or not? Do you suspect that the kidney biopsy in this patient will change your protocol of biopsy? Please said yes or no. Yes, it will change and it will affect your decision for the selection of treatment, and no, it will not affect my plan of management. Okay, the answers are between yes and no. For me, I will go with no. I will say that the biopsy result will not affect my way of management, because most of the glomerular diseases with these non-nephrotic range proteinuria, in most of glomerular disease with non-nephrotic range proteinuria, the management is general supportive treatment, antiproteinuric measures, low salt intake. You will not find any glomerular disease with this range of proteinuria is indicated for immunosuppression. So mostly the biopsy will not affect your result. But The biopsy may had a benefit that it will give you the option to know the diagnosis and the prognosis of the disease, and the future plan and assurance of the patient. But you have to tell the patient that there is a possibility that we will do the biopsy, and the biopsy will not affect our decision of treatment, and the treatment will be generally supportive. And we are doing the biopsy only for assurance to know the diagnosis. If the patient said yes for the biopsy, we will do the biopsy. If the patient is said no, is said no for the biopsy, so we'll also tell the patient that we will go for general supportive treatment, and we will do biopsy if there is no response to treatment, or if there is progression of proteinuria, or if there is appearance of new renal dysfunction. As the patient I was treating is a nurse, I told you that she was a nurse, she preferred to do the biopsy. After I ensured her that the biopsy may not affect the decision of treatment, and the treatment will usually be a general supportive treatment. So this is the light microscopy of the case. What is your spot diagnosis of this pathological light microscopy? You can write it in the chat box. We have mesangial proliferation IgA in the comments. We have FSGS. We have IgA, focal segmental. Thickened basement membrane. No, okay. Mesangial proliferative FSGS. Okay. The correct answer is FSGS, focal segmental glomerulosclerosis, not otherwise specified. This is the correct answer. This is not mesangial proliferation. The mesangial proliferation, you have to find more mesangial cells and more opened capillaries. This is sclerosis, totally sclerosis. The membrane is not that thick. To comment that the membrane is thick, you have to compare it with the membrane of the proximal convoluted tubule. Compare the membrane of any capillary, this capillary, for example, with the wall of proximal convoluted tubule. You find them the same thickness. So this is not thickened capillary membrane. And it is not mesangial proliferative glomerulonephritis. There is no proliferation of the cells. Here, there is no proliferation. It is totally sclerosis. It's totally extracellular matrix. There is no proliferation of cells. There is no cells, too much cells in the biopsy. Okay. Let's see her biopsy report. The final diagnosis was focal segmental glomerulosclerosis, not otherwise specified, the classical variant. The light microscopy here showed 31 glomeruli were seen, and the Congo red was negative. Her immunohistory staining, histochemistry staining, was negative for IgA, IgG, and COMT3. There is no deposits in this biopsy. My question is, so the diagnosis is focal segmental glomerulosclerosis, 31 glomeruli in the biopsy. My question is, I will show you the question. Question 6. Is this number, which is 31 glomeruli in the biopsy, sufficient to diagnose focal segmental glomerulosclerosis? Yes or no? You know, there is an item called biopsy adequacy. We have to see a specific number in the pathology to say that this diagnosis is accurate or not. So I showed you that the biopsy that was done for this patient showed 31 glomeruli. Is it sufficient or not? Okay, so I will show you the results. So 93% of you selected yes, that this number is sufficient, and 7% selected no. Actually, this is sufficient for this biopsy. Regarding kidney biopsy adequacy, to get adequate kidney biopsy, you must have 2 to 3 tissue cores and at least 8 to 10 glomeruli. We have 31 in our patient. Some experts suggest at least 10 to 15 glomeruli. Exceptions, check these exceptions because our patient is related to these exceptions. A smaller number of glomeruli than 8 to 10 or 10 to 15 may be enough in diffuse and global disorders as IgA nephropathy and membranous nephropathy. IgA nephropathy can diagnose from one glomerulus, and membranous nephropathy can be diagnosed from one glomerulus. A larger number of glomeruli, more than 15 to 20, may be needed if the disease is focal and segmental, as focal segmental glomerulosclerosis. So in focal segmental, not to be sure not to miss the diagnosis, you must have a large number of glomeruli. In our patient, we had 31 glomerulus, so the biopsy was adequate. And finally, minimal number of glomeruli. There is no minimum number of glomeruli. As I told you, that one intact glomerulus may be enough to diagnose IgA or membranous nephropathy. Okay, so it depends on the disease is focal or diffuse. So our biopsy was totally sufficient. Okay. The electron microscopy of the case was pending, and now we have the electron microscopy of the case. So we have focal segmental glomerular nephrosis, not otherwise specified. The electron microscopy showed that the overlying podocytes showed segmental effacement of their photoprocess. The effacement of podocytes was only in 35% of the food processes. The mesangial areas and the endothelium were unremarkable. No electron dense deposits were encountered. Check this pathology very well, the electron microscopy, because I will ask you now a question. This case is primary, secondary, or genetic, or not otherwise specified. Let's share the pool. This question 7. I will share the question now and take your recommendations. What is your final diagnosis? Okay, I will show you the answers, or you want to take more time? I see that more people are still answering. Okay, I will end the poll now and share the results. Okay, we have 22% for primary FSGS, 46% for secondary FSGS, 2% for genetic, 13% for secondary or genetic, 7% for FSGS of unidentified cause, and 9% for FSGS of undefined cause or secondary. I will show you now an approach for diagnosis of FSGS, and again I will re-ask you if you want to confirm your diagnosis or not. If you have FSGS lesion on kidney biopsy, you have to ask yourself, is the patient has nephrotic syndrome or nephrotic range proteinuria without hypoalbuminemia, or subnephrotic range proteinuria? If the patient has nephrotic syndrome, full nephrotic syndrome, and the electron microscopy showed diffuse food processes effacement, which is more than or equal 80%, our patient had only 30%, okay? And our patient was sub-nephrotic range proteinuria, not even nephrotic range without hypoalbuminemia. If there is diffuse thought process effacement, so it is likely focal segmental glomerulosclerosis, you have to treat with immunosuppression. And if no response to your immunosuppressive medications, consider genetic testing. If the patient has nephrotic range proteinuria without hypoalbuminemia, can you hear me well? Is my voice is clear? Yes. Check your internet connection, dear Samir. If the patient has diffuse thought process effacement more than or equal 80% on electron microscopy and has nephrotic range proteinuria without hypoalbuminemia or subnephrotic range proteinuria, here consider genetic testing. It is very difficult for primary FSGS to present with non-nephrotic range proteinuria, with nephrotic range proteinuria without hypoalbuminemia or subnephrotic range proteinuria. It is classically present with nephrotic syndrome. So if you have this presentation with diffuse effacement, which is not common, by the way, to have this with this. But if you have this, you have considered genetic testing, and it may be primary FSGS, but you have to consider genetic testing at first. In both presentations, whatever nephrotic syndrome, nephrotic range proteinuria without hypoalbuminemia or subnephrotic range proteinuria, and there is segmental food process effacement less than 80%, as in our case. So you have to search for identifiable secondary cause, if there is secondary cause in this case or not. If there is secondary cause in this case, you have to treat the cause, don't start immunosuppression, and start general supportive treatment. If there is no identified secondary cause, you have to consider genetic testing, don't start immunosuppression, and start general supportive therapy. If you have, or there is no probability for genetic testing, or if there is no genetic abnormality, if there is no genetic abnormality after you did genetic testing and no identifiable secondary cause, so no secondary cause and no genetic abnormality, this case is diagnosed as focal segmental glomerulosclerosis of undetermined cause. You have to monitor proteinuria and serum albumin and also treat by general supportive treatment. If there is worsening proteinuria and serum albumin and nephrotic syndrome developed, you have to consider it primary and treat with immunosuppression. Okay? So again, after I showed you this approach, again, what is your diagnosis? Even if you said it before correct, again, I will ask you, is it primary? Please answer yes or no. Is it primary? No, it is not primary, because our patient had subnephrotic range proteinuria with food process effacement 30%. So it is either secondary or genetic. So the correct answer of the previous question was secondary or genetic. This is the most appropriate answer. So when we received the report of the electron microscopy and we found that the patient had less than 80% food process effacement, we started to reassess the patient again for secondary causes of FSGS. This table shows you the full causes of secondary focal segmental glomerulosclerosis. We excluded in this patient most of these causes, like virology, like lupus, and we again re-asked here about any other medications that she is taking. There were no medications, and there were no any symptoms and sign considering any of these diseases. But with more detailed history, the patient admitted that she was born by a very low birth weight. So our final diagnosis was secondary FSGS, secondary to very low birth weight. So my question now, and this is the last question. What is your plan of management for this case? Start immunosuppression therapy, immunosuppressive therapy, A general supportive treatment, ACE inhibitor or ARB, and SGLT2 inhibitor. I know that SGLT2 inhibitors is not approved for FSGS, but we are using it off-label. Or no need for therapy, just assurance and follow-up. Okay, I will end the poll and share the results. Most of you selected to give general supportive treatment. Yes, this is the correct answer. You have a patient with secondary FSGS. The cause is not treatable. We have no treatment for a patient with no specific treatment for low birth weight. It is a history. So you have no option except for general supportive treatment. No rule for immunosuppression. Immunosuppression is only recommended if there is primary FSGS or resistant FSGS of uncertain significance, of uncertain cause with development of nephrotic syndrome. So no rule for immunosuppression. So management of secondary FSGS in general supportive treatment, immunosuppression shouldn't be used and treat the underlying condition. In general, this table is for monitoring the response of FSGS patient for the treatment. This table is adapted from primary FSGS, but usually we use it in all forms of FSGS. Initial 2 to 3 months of therapy, you have to monitor the patient every 2 to 4 weeks with serum creatinine, urine protein creatinine ratio, and serum albumin. Once the drug therapy is stabilized or being tapered if she is in immunosuppression, or the patient is stable on general supportive treatment if secondary, monitor laboratory studies every 2 to 3 months. Regarding the prognosis, what is the suggested prognosis in our case? I will mention now the factors that suspect poor prognosis in focal segmental glomerulosclerosis cases. The first is Black ethnicity, males, the response to therapy. By the way, our patient, we prescribed for her low salt diet, ACE inhibitor, ARB, SGLT2 inhibitor, and after 1 month, hair proteinuria improved so much. It started by 2 gram and 300 milligram, 2,300 milligram. After 1 month of therapy, it declined to only 1 gram. So she has marvelous response to therapy. Also, nephrotic syndrome is a bad marker in FSGS. Severity of kidney function impairment, histological findings, interstitial fibrosis is bad, collapsing glomerulopathy is bad, tip lesion is good. So regarding our patient data, do you think that she has good prognosis or bad prognosis? What do you think? Good or bad? Yes, good prognosis. She is not black. She is female. Her response to therapy was good. She presented with subnephrotic range proteinuria. Her kidney function was totally normal. She has no interstitial fibrosis in her biopsy. So the prognosis of the case is suspected to be good. That was the case. I hope that I showed you a practical approaches. The most important 2 approaches today were how to approach non-nephrotic range proteinuria in a real practice, and how to diagnose focal segmental glomerulosclerosis. Thank you for attendance. It was my pleasure, really, it was my pleasure. Thank you for your comments. Thank you. Shukran. We have a question here regarding what is the definition of glomerular hematuria. I will try to make the next case to be a case presented with hematuria to discuss in depth what is meant by glomerular hematuria. شكرا جزيلا لكم كلكم. Thank you. The lecture is recorded and I will upload it on NephroTube YouTube channel, inshallah, and I will share the link to all of you. Thank you.